Okay, good evening, everybody. Thank you. Have your attention, thank you. A very warm welcome to this Developing Mathematical Models in our Healthcare seminar. This, I think, is our 5th event now, so it's great to see some familiar faces, and thank you for speaking. It's also good to see some new faces, so very warm welcome if it's your first time to us. My name is Paul Harper, I'm the head of the Operation Research Group here, and part of the modelling unit. So this evening we've got something slightly different as a result of feedback from previous sessions. We've actually got a breakout sessions this time for more interaction. But we're also delighted to welcome a team from Ireland to share with us some of their experiences from over the other side of the Irish Sea there, and to then be part of the discussions later. So we've got 3 short talks to start with, yeah, and then there's time for some questions after. Is that right? You prefer to go and then questions at the end, maybe? So we've got, I'd like to welcome PJ, there's Peter, and then Brian. So very warm welcome. So I think you're on first, PJ, so over to you.
Thank you, Paul. Hi, everybody. My name is PJ Harnett. I work with the Special Delivery Unit in Ireland. It's a relatively new team that was established to drive health service improvement. I'll talk a little bit about that in a minute. Delighted to be in Cardiff, and thank you very much for the hospitality over the last couple of days. It's been a fantastic experience. The last time I was in Cardiff, I slept in the back of the car, having won the Hanging Cup, so it's nothing but good memories. Hopefully, some of what I might talk about in the next 10 minutes will be of interest to people, particularly in view of the fact that my background is in mental health services and in the most recent years in acute hospital services and improvement in that space. And it's been a really interesting journey for me to combine the 2 kind of fields of interest. So, just to outline a little bit of the background in terms of what's happening in Ireland at the moment. As you know, we went bust about 6 years ago, so we'll be passing around the hat at the end of the presentation. But particularly, I want to talk about this notion of solution-focused approaches to hospital and service improvement. And in particular, because of that interest in solution-focused philosophy, which comes from the sort of social constructivist field, I've been interested in the notion of positive deviance. So people who manage to cope in a way that's different from others, despite sharing the same kind of circumstances and working in the same context. So, here we have a very stark indication of the kind of cutback in funding that we've experienced in Ireland over the last 6 or 7 years, perhaps even the last 10 years. Ireland is there at the very end in the red circle, and we've had a budget reduction of 22% over the last while. Staff salaries have been cut somewhere between 25 and 30%, and a reduction in headcount of something in the order of 15%. So very dramatic and stark, brutal cuts in the health system in a way that was a blunt instrument without any real economic impact, social impact, or indeed a view to the long-term consequences. We are in the group known as the PIGS, Portugal, Ireland, Greece, and Spain, and we were the offenders that upset Germany in terms of the whole credit crisis. The UK is up there in the red, just by way of comparison in terms of the reduction in public spending in healthcare. And this information is worked on by a particular group of people in Trinity College, the Resilience for Health project, which looks at the impact of austerity on the whole health economy in Ireland. So those kinds of reductions have been taking place in a particular context as well, which is sort of double whammy. On the left-hand side, you'll see the changes in population, and particularly changes in population over the age of 65 in Ireland over the last 10 or 11 years. And you'll see that our demographic change has been steeper than that of the rest of Europe. And one of the things that we've been discussing in the last couple of days with our colleagues is how the modelling that you've been doing has revealed the kind of changing nature of acute hospital customers, if you like, and how that requires a rethink, a redesign in terms of what it is that they're seeking to do. The other report that's issued recently is a report by Dr. Martin Connor, who is an advisor to the Health Minister, And he has sort of disclosed, if you like, the idea that there's been a disproportionate reduction in health spending in Ireland relative to other areas. One would imagine that there would be a relatively equitable cut, but that's not been the case. And health has suffered from a kind of bad rap in terms of being a football for inefficiency, or being a byword for inefficiency in the public sector debate in Ireland. So the conclusion from Mark McKeon's report about a month ago is that we're at an inflection point in Ireland where we're going to do long-term serious damage to our health system unless we take some remedial action pretty soon or immediately. And that that's going to have catastrophic consequences. And in fact, one of the things that emerged out of the Trinity Resilience Project is that we are, on an industrial level, managing to replicate Mid-Staffordshire, which is not an achievement that we necessarily want to be associated with. So, I work with a special delivery unit, a small unit of 10 people. We were parachuted in on foot of a crisis around trolley weights in emergency departments. And our initial public image was that of the Gestapo, who would go in and sort people out. Thankfully, that's not people's experience 2 years hence, and we seem to have hopefully earned a reputation of honest brokers in the system who might have something useful to offer. This minister is no longer with us. Well, he's still with us, so he's no longer the minister. And we have a new minister for health. Not that guy, but this guy. So, similar to here in the UK, we have waiting time targets within emergency departments, and thus far, very few hospitals in Ireland have managed to achieve this. Here's a sort of situational status analysis that we have visibility of 3 times a day. This is a sort of census that's taken nationally of all of the people who are waiting on trolleys in hospitals after the admission, the decision to admit has been made. And so what tends to happen is that those hospitals with the very high numbers in red are the ones that get the focus. This simply compares the same day last year, and with a fair degree of predictive reliability, we're able to tell what will happen on Tuesday on the 2nd of November in the given hospital. But interestingly, that doesn't necessarily change the response. But I'm interested in those people who appear to be positive deviants, who, despite the same context, who have suffered the same cutbacks, have somehow managed to maintain a level of performance that's impressive given the circumstances in which they worked. So, very, very quickly, the 2 people up there on the left are a husband and wife team who developed solution-focused interventions in mental health services in Wisconsin and the States through a series of flukes and accidents, and really driven by curiosity around what allows people to change. And I've been interested in what allows organizations to change. What is it that's different about an organization that can cope and that manages to achieve better performance than its peers? I was attracted to their particular philosophy probably in the late 80s because it got away from the established paradigm of deficit-based conversations. And most of our traditional attempts to fix a problem tend to gravitate towards diagnosing the problem and seeking to fix it by applying some kind of solution. And that brings with it a whole host of baggage around notions of resistance, around a sense of hopelessness and helplessness, being stuck. Instead, the solution-focused approach seeks to understand the opposite. It seeks to understand what is the positive deviants are doing that we can replicate, what is the secret sauce in their approach, and how might we learn from them. So that particular approach draws from the sort of DNA of a number of things. It draws from systemic family therapy, which borrows from physics, positive psychology, transactional analysis, and some of the stuff around leadership and motivation. And all of that seems to create a sort of way of looking at the world that I think is much more helpful and useful in organizational change and development than the traditional approach. So, I'm not going to dwell on this, but we were having a conversation this morning about the organizational narrative. What stories do people tell each other within the organization, and how does that become constructed as people's reality? And what impact does that story or narrative have on a whole host of things, ranging from motivation to the belief that things can actually change? And some of the things that we've encountered are that when we're faced with a very complex problem, people tend to try and apply complex solutions. And in fact, the challenge is to make something simple. One of the very shocking issues within the Irish health system is the treatment of older people. When we looked at a number of different hospitals, this wasn't unique to any one hospital, it's pretty much the same experience. Hundreds of people over the age of 75 who wait to be admitted to a bed for 25 hours on average, which is an appalling indictment of our system. So, thinking about what allows organizations to change, thinking about the philosophy that might be brought to bear and the conversations that might be useful was something that a colleague and I, Willie Reddy, were very interested in. And intuitively, we felt that going in and having a conversation about improvement didn't really resonate with anybody. And we began to look at some critical factors, if applied in a particular context, how that might drive an organizational improvement. And the kind of step change that you see in performance from an average of 20 people per day waiting on trolleys to less than 5 per day seemed to us to be more remarkable than one might expect of a normal process improvement type of intervention. So we began to catalogue some of the factors that helped, both in terms of leadership, planning, and process, that helped to achieve that kind of result. And we began to replicate some of that in other hospitals. And some of the hospitals that we work with just adopted a couple of very simple interventions. So, for example, on the right, in St. Kills, they just undertook earlier discharges and weekend discharges as their project, and that was as much as we asked them to do. On the left-hand side, the Mater is a very distinguished hospital in Ireland. And again, the same kind of ingredients were at play, but their performance seemed to change, and I'll talk a little bit about that in a while. This is an example of last week of a hospital, again, with similar kind of interventions applied, but not necessarily the mechanistic aspect of it, but rather creating the conditions to have a conversation that's different. So, in the Mater, the hospital that reverted back to a poorer performance, one of the things that was interesting was, predictably, some of the egress capacity that was required to maintain the flow of patients was charted, understood, and subsequently ignored, with a fairly predictable deterioration in performance and the improvement undermined. And that comes not just at a cost to patients, obviously, but a cost to the leaders of the organisation who put themselves out there to gain the trust and credibility that was hard earned but easily lost. So, just to wrap up, I suppose the experience that we've had over the last 2 years sort of lends itself to thinking about how all of these factors are important in terms of the mix. And I've been really interested in seeing some of the work that you've been doing here in Cardiff around modelling and simulation to think about how does that drive the kind of improvement that, and how does that transparency and visibility play a part in the dynamic around achieving change. And there are the mechanistic issues around clinical pathways, care and case management, the care delivery systems, how we organize all of that infrastructure, and that's no doubt important. Equally, things like planning, the role of data, and so on, are critical ingredients. So the how and the what is well attended to, but what we feel isn't well understood is the whole issue of meaning and the why. And in particular for clinical executive leaders in the organization, or indeed everybody in the organization, how does the work that you do, how does the data that you look at, how does the process that you're involved in, how does that have meaning for you in terms of your professional aspirations, the ethical value base that you have, the kind of thing that motivated you to work in the first place. And I believe that the organizational narrative that runs through the organization is the kind of oil that greases that engine. And that talks to the values, beliefs, the organizational integrity that's there that allows that to be facilitated. And the hospitals that improve seem to share some common factors, but the thing that leaps out at me is that kind of leadership that taps into the notion of meaning, that lives by a certain set of values, and that creates a climate of curiosity and of a willingness to try things. So we're still testing how those ingredients interact with one another. We don't have the benefit of some of the simulation and modeling work that you've been doing. So it'll be intriguing to see how some of that might begin to drive the narrative even further. So that's a very quick and dirty outline of where we're at, what we're doing, and some of the kind of journey we've been on to date. And of course, all of that is done in a very extraordinary context of austerity. Okay, thank you.
Thanks, PJ. We'll go straight on to Brian.
Hello, everybody. My name is Brian McKeon. I'm the Planning and Performance Manager for the University of Limerick Hospital Group of Hospitals in the Midwest in Southern Ireland. I'm going to take the scope of the discussion down a little more into our hospital group, explain a little bit about how our group is structured, and some of the challenges that we have, and which there are many, some of them are similar to yours, but so geographically, we're located in the Midwest down here in Ireland. The country we're split into 6 hospital groups, 6 main hospital groups. There's one also for children, it's a pediatric hospital group. We're here with a population that's a little out of date. We have a population of about 440,000 people. We comprise of 6 hospitals in this region, one in Clare, in North Tipperary electorate area, and in hospitals in Limerick. So we have, I found it was interesting, the development of a new central hub hospital, because this is a model that we rolled out a number of years ago, and we are now investigating the impact of that. We have undifferentiated take Model 4 hospital, that's called, under the National Acute Medical Program. So this hospital here is the only hospital with an ICU and a HDU. And a neonatal HDU. We have a Model 2 hospital, which is up here in Clare, with 50 beds. A Model 2 has no HDU or ICU. Model 2 as well in Nina. We have the University Maternity Hospital, which is situated on a separate site from the main hospital. St. John's Hospital, traditionally and through an adaptation of the program, is a Model 2S. Which means that it also doesn't have an ICU or HDU, but does 5-day surgery. And Croom, which is a specialty orthopedic hospital. So the challenges that we face in our group, through the restructuring and for other reasons, and austerity and other factors like that, are we, apart from restructuring the actual hospitals and their function, we also embarked on a change to a directorate management structure. So we have medicine directors, perioperative, maternal and child, and and Diagnostics Directorate. They span all the hospitals. They cover all of the functions within their specialist area throughout the entire group. We are the smallest network, we are the smallest group in Ireland, which has advantages and disadvantages. We have our standalone maternity hospital, which obviously is a major clinical risk and disadvantage. That is scheduled in the future to be built co-located with the major hospital. The restructuring left us with only one emergency department for the entire region. We have a severe problem with overcrowding. Our trolley issue is in the national newspapers. We have very bad trolleys, and our patient experience time is, fluctuates with that. We have a new emergency department which should be open in 2016, so that will alleviate some of the issues. Outpatient clinics, we've quite crowded outpatient clinics, sort of 30 patients attending a clinic from 9 to 1. And bed capacity issues. And staff recruitment and retention, there was a moratorium on recruitment brought in as part of the austerity measures, which meant that no posts could be backfilled, no posts could be filled. I think even frontline clinical posts have to be signed off by the minister personally. So, also with that, we have a series of a number of incentivized redundancy schemes, voluntary redundancy schemes. So these are the goals. So we'll build a lovely big model, and it'll tell us what to do, and we'll be grand. No, we have what you'd love is a number of different techniques to come to the table. So at the moment we don't have modeling. Modeling occurs through research, through people's masters or PhDs in the back room, and it's not brought into the fore. It's not used. Empirical methods, quantitative methods are used with limited use of them in decision making, strategic decision making. But there are opportunities. I mean, we have opportunities with combination optimization for rosters and theatre scheduling. We know we can target discrete areas such as the ED, OPD, and labs with discrete event simulations. And we hope as well that eventually with the right data infrastructure, you could build system dynamics models that would lend themselves to strategic decision making. But we're a bit away from that yet. So my major concern as performance manager is meeting metrics and targets, and that's fine. But I also have a role in ensuring data quality and ensuring a data infrastructure that will support the organization. So at present, we have divergent systems. So as I said, we have 6 hospitals, we have 6 PAS systems, all with individual numbering. So we can't track patients as they move around the region. We have PAS, we have a HL7 ADT links unidirectional to radiology systems or laboratory systems, and the granular level of interrogation of those systems is also absent. So these divergent systems cause us major problems. We have a lot of silo and ad hoc data capture. So CNS is capturing information for nurse management or national staff and their clinical programs, capture information as best they can using Excel spreadsheets, access databases, manual capture. And we have, BI is a bit of a misnomer to me. It comes in time, but the major thing is having centralized silos, and that's where we need to get to. We're also preparing for trust status. The concept is to bring hospital groups on and give them independent budgetary autonomy and decision-making autonomy and invest them in trust status. So we're on our road to that. Some of the people issues, let's say, not for any fault of the actual people, but it's probably more the support of the system, supporting people to capture their information. Over-aggregation is a big problem we find. So new metrics come out, we visit CNSs, saying new national targets for you, but what they've done is it suited them at the time to count all patients in the month. But now it really doesn't suit us because we needed to see individually the age of those patients and track back that type of stuff. So over-aggregation Incomplete, if people are off on leave, data very often isn't filled in, or inaccurate information. The data quality of many of the core system inputs. So we have to address the data quality of waiting lists, their completeness, and the referrals. Are we getting a true sense of all the demand hitting the system? And as another idea in the people section, the national moratorium has led to a reduction in any form of analyst or ICT staff. And we also have no specific roles, like I believe the specific information analyst roles and defined roles in the NHS. In the HSE, all ICT staff fall under administrative grades and have no defined structure. In local governments in Ireland, there are specific technical and analyst grades. So I believe that's a limiting factor. Some of the developments we have which might assist us, we have a new path coming. The new national path will be coming in about 18 months' time. And that will merge 6 systems. We have one voluntary hospital in our group, which means we have some data protection issues around that. But it'll merge 6 systems together. So we get greater visibility on length of stay, let's say the experiential length of stay, moving from acute into rehab and all that stuff. We'll have a new single regional identifier, which will pervade all the other systems as well. So that's very, critical. There's active work going on. Actively, we're supporting staff to structure their data. We're going visiting all the silos of data within our capacity. We're moving through the place, structuring all their data, trying to normalize it, trying to get it into mechanisms that will allow us to suck it in at some date in the future. The new paths will have a shadow DB, which will have like a 3-second replication, which will allow us to actually interrogate that at will. And this is still in the room. So we're working through the organization. We have data quality with new roles, and the communication. My role is relatively new. I started at the start of the year. For communication, we have a communication officer now who's working. And we're working together to talk about the type of information that people want to see in clinical areas and in administrative areas, to drive the conversation about the type of information that matters to them and how that might help improve performance. We have national visibility through the SDU, and other national bodies are taking information up, Royal College of Surgeons also, and the trust status also brings with us a new payment method for patients called money follows the patient. So clinical coding, ICD-10 coding is imperative in that to try and drive revenue. And we have some NSC programs in the region, which I think are getting traction with health informatics. There is mathematical modeling, supply chain management, supply chain management. And the group, as the group consolidates, a lot of people in their old silos, so in some of the regional hospitals and in the voluntary hospitals, we expect that they will come in together and consolidate into a single resource. So that's part of our journey from a major, from the individual hospitals to a single central acute hospital. But all of that then, when we have a lot of that in place, we can drive through simulation modeling, or we can bring those things in. I mean, without correct data that you can stand over, without your data being verified, you're always at the point where somebody can question it. So you build a lovely model, and the first thing is, well, geez, that's nothing like the way I work. I mean, I work completely different from that. So we need to do all this coding, and that's one of our major challenges. We're compared to you guys, we're starting out in our journey. So hopefully we'll get somewhere near there. Anyway, that's.
Hi folks, my name is Peter Williams. Here. I put my talk together in terms of reflections on the Irish system and on simulation, the notion of interaction with and for practice some degree, maybe some of what I was going to say has maybe been preempted, particularly by PJ, with some of the national statistics that I've produced. But the notion that I have is that we have a national system, we have local activity, we have a lot of very disparate locations. We have the changes in structure, the positive changes in structure, and so on. But against that, lying in the background, is a certain history of maybe where we've come from in the past few years. And I'm trying to see if I can tie together the notions of the national system, planning, and so forth, where people, particularly managers, feel they are, particularly how they felt they were 5 years ago. So the national survey. Try and tie that together with notions, the hypothesis that modelling, simulation modelling, as we've noted in the group here, would have for us the possibility, the strong possibility of making some breakthrough gains. My slides I prepared, not really knowing how the time would go, so I put in rather a bundle of things that I'm going to tend to slip past some of them, but they will sit on others, and try and get some sense of that time together piece. I'm an engineer, I'm a lecturer in operations management. We used to teach industrial engineering, we teach production, supply chain management in my department, and we've got an enterprise research centre where we do both applied and blue skies type research, and some of our colleagues do embedded work in the way in which the survey area has been interacting with the health system, somewhat in a similar mode, but not the same level. PJ mentioned earlier about austerity, and I thought it would be useful to just put down some numbers. This is annual growth rate of health expenditure. Ireland and the UK, sorry, I don't have figures for Wales. I'm relying on OECD, and they have, the UK comes with the full bundle. And you might hear we have UK 5.853 and so on presented up here. And here's Ireland, and we're ticking along, and then we're really getting perhaps a bit beyond ourselves, here up here, and then we hit the cliff, and we put it, and up again. So that, in a sense, is where we've been. And this is just only, because it's OECD figures, and I want to get a comparative set, it's only up to 11, and bad things that continue to happen. To bad or 4 or 9, until you look at 11, of course, in the detail in more recent times, and you fell off the cliff. And interesting here is that you take the standard deviation of all these numbers, we find that here we are in the UK, we have a nice UK, we have a nice smooth ride, and I can't speak for Wyatt, but we are on, we've had quite a rocky ride, and they will come in Slovakia and various others. In terms of rank, we were spending 9th, so we went to 16, and we went up 2 and 3, we're really riding high. And then we start to come proper. Here we are, 2nd from the bottom, and nothing to show really that has likely to change. Again, in terms of position, we were, it's 6th there in terms of this, but in terms of variation, we're way down. We've had, we're in 23 out of 32 in terms of rockiness of ride. I have other comparable folks there, but I think it's maybe from that. In terms of population expenditure, and so on, we have a population which has grown 4.6 million, and apparently official figures 3.1. I don't know how that stands up. People have been talking about 3. UK 59, 64, and so on. Total health expenditure as percent of GDP 8.9 versus before, but we spend, and this is where the GDP figures that we have, as you may know from mentions of Ireland, we tend to gather a lot of GDP, which perhaps maybe isn't as much really GDP as it might be. So that hides the fact that we spend $3,700 on OECD figures versus UK $3,505 per person per head. What's interesting here, and again reflecting on what PJ was saying, we've gone from 2004, 5, 9, 11, we went from a public health, total health expenditure. So the health service executive is much of the budget we talk about is public. We've gone from that 77, 76, 72, by 2011 we dropped to 67%. So we're relying a lot on out-of-pocket and private insurance in the UK, but maintaining very much more public figure. In terms of infant mortality, we're broadly speaking doing okay. Adult mortality, likewise, privately life expectancy, likewise. In terms of World Health Performance in 2000, just the latest one we can lay our hands on, we were doing 18,190. 1990, UK would be 18,190, so we're neck and neck. In terms of World Happiness Report, essentially we are 18th and the UK is 22nd, for what it's worth. So broadly speaking, in the world's state of things, we're not too bad, but against that, the services have to be provided, and it's a rocky ride providing. Okay, so in terms of the health system, I think it's useful to refer back to the year 2005, when we went to what was in effect a monolithic health system, where the health service executive subsumed all of the duties of 9 health boards. There were 11 originally, but 3 have now measured together, and very roughly comes to 80% expense. We have a National Hospitals Office, a primary continuing community care, a small public health, and we have shared services. So this are basically the 3 major pillars. Standing beside, we have a health information quality authority whose prerogative to look after quality and patient safety. There were changes in 2009, heading towards the map that Brian showed you, where we have, in more recent time, we have these regional areas. But I put in the word trust there. That's not correct in terminology, but that's in fact where they're headed. 2011, we had this special delivery unit from the new minister came in 2011. He said about the waiting list would have to be tackled, and he installed a special delivery unit, amongst a number of other initiatives. But since then, what we've had is a certain breaking up of the monolithic system. For example, the Child and Family Agency have been split off. So in terms of horizontal connectedness, this, in terms of hospitals, we're getting connectedness in terms of dealing with outside hospital issues, then clearly taking an important program like this off post the problems of integration. Now, I am going to I'm just going to stop. I want to say something very briefly about the National Service Plan, because it's a National Service Planning process which ties this together. To remind me, this is I'm stopping here. The National Service Planning process which ties this together, at which the highest, at the lowest level, for example, it's Brian's job to set up the planning at local level. These plans are aggregated upwards towards the national plan and presented to the minister once a year for approval. The point about this thing is that there are many targets sitting there, but the problem that we have is that we have some questions about that in a sense, there's a rhetoric from above and there's a reality from below. And the two are not meeting very well. And this, in a sense, is where we feel that modelling and what goes with it, which is the connectedness with the parties, getting the parties aboard to produce a realistic and workable and sustainable performing plan. We feel that capacity planning, as the community here knows, is something that we are missing. And really, that's why we've come over to Cardiff to find out what, to use our expression, you guys are doing. And we've spent yesterday and this morning being very well informed as to the possibilities and perhaps things that we could do. We're a long way behind. We recognise we have a need, and we want to draw a line on that.
Okay, thanks to all three. To keep to schedule, we've got time then for breakout. There will be time in the session for breakout sessions themselves to pick up questions that PJ, Peter, or Brian. Okay, and there'll be time maybe after as well, after the event as well, if you want to ask specific questions. But to try and keep schedule, we're going to jump to the next session. So we're going to have John.
I'm going first. Yes.
Go first, John.
Yeah, the pointy thing, some of it works actually. Is that okay? Yeah, well, I need the glasses. Good afternoon. I'm John Frankish. I work for an Irish and Welsh group team in an Irish and Welsh University Health Board and over in South East Wales. I'm with Matt and Wyatt. I'm going first, and this is kind of set up for the breakout session. I'm just going to say a few words by way of introduction, set the scenes, and play the naive, grey-suited NHS manager. Matt's then going to come in and kind of explain the concept we want to try out with you in the breakout session. And Jenny, she's going to actually come and organise this. She's going to organise the orders. Thank goodness, otherwise we wouldn't be here talking to you today. This came about because we knew we had the mathematical modelling seminar, and I am the service lead for the mathematical modelling unit in an Irish, which is quite funny, for reasons I will come to explain in a second. And they said, "Oh, John, would you do something?" And I said, "You did go to Portugal and you spoke there," and I thought, well, that's never going to be good enough for Cardiff. You have to do better, which is why I dragged Matt into it, really, because he's going to help bail me out, really. I wanted to start by, I was going to ask you how many people in the room had a qualification in mathematics beyond O-level or GCSE, actually beyond 16. But then I realised that probably that's a foolish thing, because we ought to speak to Professor Ian Stewart, who does that wonderful geology programme on the telly. I love geology. Something to do with that as an archaeologist, I think. He says, when he talks about geological communication, he said, "I've got you lot, not interested in you lot. It's the people out there who I haven't got yet, who I want to attract into this subject area." And the reason for asking, who has a qualification and who doesn't, is that because if we believe what psychologists say, actually we tend to work from what is familiar, don't we? We work with what's easy. And if you haven't been taught or learnt or don't consider yourself particularly rational or empirical, I'm sure that's what that means sometimes, the challenge of mathematical modelling is quite difficult, because you won't get it. And you won't want to get it, because you won't want the embarrassment of people realising that you may not understand this stuff. Well, I stand up. Okay? I really don't understand it. I'm never going to be capable of understanding it, which is quite entertaining. They put me in charge. There we are. I'm not in charge in a loose sense, but some of my press making go forward is the math part. Do you know what Danny said? I knew on part of the TV said, "Don't screw up." And I went, "Yes, I'm in." Because he only says it to real team members. So my second slide is this, because for those of us who are not initiated within the magic of maths and things like this, it's the magic one, isn't it? It's brilliant. I don't really know how it works. I know, Bevan, how does it work? And so the task that we wanted to set up for you really was to start to talk about how do we help people who perhaps aren't literate in some of this stuff. How do we help people to start understanding how mathematical modelling works in a healthcare context? That was the kind of concept. So, and in doing that, really we want healthcare to understand how it works a little bit, so that we can share that with mathematicians, so that mathematicians can share what they do in that world. Now, when we went to Portugal, Paul and I, yeah, you're getting it. Yes, that's my slide. I think I made you speak to it. We put up this list of magic spells. Because if you don't know what any of this means, it may as well be a magic spell, mightn't it? And when we put this, actually comes off our website for the team. And we have a list of magic spells of things that we tell people that we can help you with these things. To an awful lot of our organisation, they don't mean diddly squat. And some of those people, regretfully, are actually quite senior. I wonder how many senior NHS managers, I Googled this last night because I was a bit late, lastminute.com. How many NHS managers, could that tell anything about statistics to do with the qualifications of NHS managers anywhere in the UK? Couldn't find anything. Okay, maybe I'm not a very good researcher either, but I did do a little bit of PhD work in the archaeology one, so I never finished it, but there we are. But I do know how to find my way around that. I couldn't find anything. I thought it was quite interesting, quite revealing. And then Paul also put up the further slide, which was trying to say, well, how would you deploy all these magic spells? Well, this seems okay, doesn't it? Because everybody understands clinical, operational, strategic, don't we? But I wasn't really sure that was going to be enough actually to help us understand. Because when I think about the service these days, I think of it like this. Lots of bowls of spaghetti. And this is my bowl of spaghetti. Actually, it isn't. I got these off there. But let's pretend this is my bowl of spaghetti that I made. Okay, this is our hospital. They are our hospitals, your hospitals in Ireland, are all a bit like bowls of spaghetti, aren't they? They all look like bowls of spaghetti, but actually they're all quite different. And that causes all sorts of problems when it comes to comparison. We do lots of spurious benchmarking, particularly with numbers, which don't help us, rather than actually analysing what's going on in our own system. But that's actually also quite a difficult concept to get over to people, how you actually understand where you are within that bowl of spaghetti at any one particular moment in terms of the problem you're trying to solve. Because when you delve into the spaghetti and get into a quantum level of what your sauce is like and what herbs and seasoning and God knows what else you've used, you're getting into quite a lot of interesting area. So we need to find some way of understanding that. And so why I've hired Matt for the afternoon is to talk about this kind of stuff. Now, he's very kindly shared this slide. Frankly, just like modelling and mathematics, I'm an NHS manager, mate. I'm in a grey suit. Okay? I was a nurse. I can just about do computations for getting your drugs out to you safely. Just about. But when we get into complexity theory, I haven't got a clue either. So how are we going to explain to people what their spaghetti looks like when they actually haven't got into that either? And I suppose that's the challenge that we're setting forward. This slide is Brian Castellani's, and I do like this quite a lot because it talks about kind of different development of different types of approaches to complexity over the years. And what I love about this is it's just as much spaghetti as how hospitals look. And it's entirely dependent on who you are and where you are and what's most for. Well, that's actually quite interesting as a concept to me because knowing where you are in the spaghetti is quite useful. But also I like the idea that my view of the world is perhaps as valid as anybody else's, because that's what it certainly feels like in this one. So Matt's going to talk to us about how we negotiate our way through complexity thinking to help us to get a model that we're going to use to understand and break out how interactions are taking place within all this spaghetti and how we might think about applying mathematical modelling techniques. I think we have the luxury, just to think about the kind of Irish challenge, we seem to have a luxury still because we're not in the same position as you are. There's this emergent thinking for us in ABCI after about a year and a half of trying to sit there and say, how do we explain this difficult stuff to people? Whereas you seem to be in a kind of maybe more top-down environment in terms of thinking how we do that. I think that's quite an interesting difference for us, but we'd like to explore that. But the best thing I can do now is shut up, now I've set the scene, and let Matt get on with it and set things up. Is that short enough, James? Good. I was told to be brief.
Yes, thanks, John. John, you can sit down now.
You can repair that.
Yeah, if we don't give him limits, he'll go on forever and talk about archaeology and Greece and all kinds of things. Oh, yeah. Sit down.
I know my face.
Right, Matt. Evening, everybody. I don't normally need a microphone, but I do talk a bit quickly because I've come from FD. Right? Don't hold it against me. So I'll have to go relatively quickly to get you to the time to break out, but I'm going to do my best to describe for you, if you like, a bit of a heuristic or a framework that we're going to use to try and make sense of the question we'll set you, which is how does different bits of the health system work and where do different ways of doing maths fit in that system so that it's complementary. That's basically where we're going to get to. But we're going to move from that spaghetti diagram, and I thought what I'd do is I'd just explain a very simple little bit of science to begin with, to give you all a common framework, which you will be equally ignorant of. Whether you're an operational person or a doctor or a mathematician, you'll know just about as little as the next person next to you, so we can have a lovely conversation, because nobody's going to be an expert, isn't it? So there are no correct answers in this, and there are no wrong answers either. It's a framework that hopefully will help to lead a conversation. So a little bit of science. I thought in a maths department, we may as well go to maths, and we're going to use a very simple chart. Those are two axes. Even the people with an O level in maths, that they failed, will be all right with that. I passed. You're all right with that, you passed it. I'm going to try and describe the whole health system on one two-dimensional chart. So you're going to have to bear with me a minute, but it should be at least fun and sensible. The axis going up vertically is going to be population need. You know, what demand is out there in the population. And the axis going across the bottom is going to be the type of service. Is that all right? Or the type of response to that need. The scale, in this bottom corner, we've got kind of general, universal, big things. So the population need is a big general need. And as the axis goes up, you end up with an individual predicament. One person at the top in a very unusual situation. Many people at the bottom in fairly common stuff. Is that all right? Nod at me. Nod at me. Okay, cool. As we go across the bottom, in the corner of the axis again, we've got large, universal, general type services. And as we go along the axis, it becomes very technically specific. Where it may be a service that only does one thing. Does that make sense? So you can see the pattern of that kind of scale. We're not going to go big on the increments. We'll have two on each, if that's all right. Is that okay? And on the vertical axis, we'll go predictable and unpredictable. Because it's population need, and there's a lot of it, it's kind of predictable. We know that there is a lot of certain stuff that comes in through the door on a day-to-day basis. When we go to the service type, we start again big unstructured stuff like public health information, generally knowing how to eat and drink things and stay healthy, to quite heavily structured stuff. Because when you've got a very technical service, you've normally got to build a building to put it in. You've got to attach it to other specialties that it's attached to, and you've got to supply it with stuff. And it can be quite heavily structured. Does that kind of make sense? Is that right? So therefore, we have classic four-quadrant business bollocks, if it's known in the business department, just across the road there. And what I'll do then is I'll kind of describe the typical place that you might, in a health service, come across people that fit into those four boxes. These people in the bottom, predictable and unstructured, they're kind of at home. It's normal. There's nothing unusual happening. These people are in the house. As you go across into structured stuff, so still predictable, structured, these people generally in a hospital, because it's big and predictable. We've got the department set up and it's already there. As we come out of the hospital into something that's less predictable, we're kind of in the A&E or still in the back of the ambulance. Do you get that? There is a structure. We have got things set up, but we don't know what's coming in. We know there is going to be a car crash somewhere. We don't know exactly where or exactly when. Does that kind of make sense? And then as we come out of the structure into the unstructured, unpredictable box, that person is in the street. We haven't found them yet. Or they sleep in the park. Does that kind of make sense? So we've got this kind of pattern. And normally, if we find somebody in the street, you have to take them through the A&E into the hospital before you can get them home. So there is a kind of a way that works. The typical activity, so if you go to the bottom, for people who are in the house, the typical activity is that person needs some advice or information on a few routine tasks. Put your feet up, have a drink, go to sleep, take some paracetamol, you'll be fine. Yeah? Okay. As you go from that unstructured, predictable across into the structure, the person in the hospital needs the right treatment for a particular problem. We've diagnosed it, we know exactly what it is, and we know the answer for that thing. Is that going to make sense? As you come out of the structure and into the unpredictable, in the A&E, what we've got is this thing where we need to consider the whole person over discrete problems. They may well have a broken leg, but let's save their life first, before we worry about fixing the leg or repairing the sutures and all that kind of stuff. So you see where we've got to think of the whole person then, before we do discrete problems. And then if we go into the street, what you've got is a mess. And the first thing you've got to do is try and figure out what on earth is going on. There's a unique mix of stuff that you can't see from just your initial observation. Does that kind of make sense? You've got an idea of the different types of work. And when I talk to clinical teams, most of the sort of doctors and nurses and therapists, when I present that to them, they go, yes, I understand that, and I can tell you the names of some patients that fit neatly in those different boxes. If I simplify that slightly, Person in the bottom corner's got a life to be getting on with. They don't really want to talk to you or be anywhere near your hospital. Leave me alone is most of it. That person's got a problem, solve it. This person is in a crisis that they need to get over, and that person's got a mess. Are we all right with those kind of general words? Life, problem, crisis, and mess. Are they sufficiently different for you to have in your mind the characteristics of those different four things? Is that okay?
Is the understanding that a mess is worse than a crisis?
Well, the idea is that you don't know. You've got no bloody idea, because it's a mess. Whereas a crisis is that thing that's about to happen. They could be really dead. But somebody could quite easily go from a mess to a crisis, couldn't they? Interestingly, though, it's very difficult to go from a mess down to a normal life again. It's almost like a big step there. And this particular shape and that boundary between a life and a mess is described rather well by Professor Dave Snowden. Do you know Dave Snowden and his connecting framework? A very interesting reference I'll give you afterwards if you want to read some of that. So let's have a little think now. That's what we prefer. We prefer the health system to work like this, where the vast majority of it is absolutely normal, people getting on with whatever they get on with, and there's a thin sliver of clever stuff that is there for just when they need it. So we prefer the system to look like this. It doesn't look like that. If we look at it from the institution's perspective, so I'll change the size of these boxes to make them kind of relevant, what we find is that 60% of all the money is there. 60% of all the money is jammed into that structured, predictable stuff. It's usually called a department, and it's got an ology next to it, and it takes 14 years to train somebody to be an ologist, usually. We then got about 15% of the money is spent on very special, sexy stuff, which rises out of that, about saving lives and doing regional spinal reconstructions and marvelous things like that. We spend about 15% on trying to keep people at home in their normal life. And about, in Wales, definitely, but in the UK in general, we spend about £1 in every £10 in the health service on people in a mess. Either coming into a mess or coming out of a mess. And for example, finding people living in an isolated situation and they end up in a continuing NHS healthcare funded package of care that costs an absolute fortune. The way we manage this from the institutional perspective is rather interesting, because what we do is that. We chop up the nice structured predictable stuff into boxes. We'll put a code on each one of those boxes. We'll put a pot of money in the boxes, and then we'll beat it with a stick to make sure that it only does the thing that's on the label for the box and only spends the money that's in the box. Are you familiar with that technique? You might be, yes. Carrot and stick, bite that, smash. What does it actually look like from the patient's perspective? Well, and I have to say, because I work a lot with frontline teams, I'm actually work for Public Health Wales as an improvement advisor, which sounds very, very posh. I'm really a professional interferer. If somebody asks for help, I sort of turn up, and then they ask me to go, and I say no. This is too much fun. So staff have got a very similar feeling to the punters, and the punters say it feels more like that. But most of it is a bloody mess. And I can't understand how to navigate my way around it. I don't understand how the bloody thing works. And whenever I try to do something really extraordinarily simple, like contact my GP and get an appointment, I seem to jump through a huge pile of stuff. We invent more and more crisis things to deal with more and more predictable stuff. Anyone seen an acute response team? Marvelous. Then we try and spend loads of money by keeping people at home, by putting more structure out into the community, and in the end, the little box in the corner becomes so heavily under pressure, we micromanage the living daylights of it. And in that little corner, with those lovely guys in the grey suits and the bags under their eyes, who have been taught how to manage this bottom corner, look at the big mess, and what's their solution for managing the mess? That. Cut the mess up into more little boxes. Create 140-page forms. People fill in. And of course, what happens if you add more rules to a mess? You get a bigger mess. You see what happens? You end up with a lot of this. These are the shouty, besooted people who get really frustrated and start shouting, and you get broken relationships and all horrible things happen. But it's not that I'm allowed to pick on these. I have been a general manager in the past. These poor bunnies, it's not really their fault because they're taught something from an early age. They're taught this. They're taught that you must have a perfect, beautifully engineered little ship of order. Because the only alternative to the beautiful engineering is the vast sea of chaos, isn't it? So the only answer is engineering little perfect things. But this is where the system science comes in, and where we're leading you to, because if I was to go back in some ancient history, the chaos side of it was that in the past, we thought that anything we couldn't explain was the result of an angry god or a monster, wasn't it? Gods and monsters create chaos, don't ask about it, it's up in heaven. Then this bloke turns up and says, hang on a minute, if we're going to make some decisions, we surely could do it as evidence. I'm sure you've all read Principia Mathematica, haven't you? It's bedtime reading. Yes. Some people nodded, right? Some people nodded. And he's brilliant, isn't he? Because it's been 300 years worth of fabulous industrial development that's given us pretty much everything we have today. It's absolutely wonderful. But of course, sticking with the physics envy in the maths department, obviously, what happened was more recently, this guy turns up and says, well, it's not quite so straightforward, I'm sorry. It's all a bit relative, sir. So I won't go into the philosophy of this, because that could spend a long time on that. But if we accept that's a mess, okay? And this is all nice and neat and straight and tidy. And in the middle, it's kind of relative. Is that okay to leave it there for now? Is that okay for now? Yeah, okay. Oh, by the way, in case there's any IHI, which is healthcare improvement plans in the room, tipping that on its side and calling it a driver diagram makes absolutely no difference. Okay? It is still a hierarchy diagram. It is still about some god being in charge. This funny 4-box model, it came from some genuine system science where we use that 3 systems model, that there's a complex thing in the middle where we live. There's a nice ordered, neat and tidy one, and there's a messy one. And we use this to actually observe clinicians in practice. We commissioned some research at the University Hospital Limerick. We filmed people in action, and we tried to figure out how they respond to these different types of demands. And what we found very quickly was that the teams actually changed the way they behaved and the way that they practiced, dependent on the demand placed in front of them. And they did that hundreds of times a day, which sounds really weird. So we did some real science. You'll have to believe me. We gave all of these different types of systems characteristics. We found the characteristics, we filmed them, researched them, and there are lovely reasons behind all of this. You don't need to understand it all. If I just tell you that, is that okay? It's gods and monsters over there, and it's Newton on the other side. And of course, this is where the complexity comes in. Because what we found is most of the time, the teams were working not in these 2 extremes, but actually in some middle, real-time, complex interaction kind of place. And what we focused on was the decision-making that they did. And it's a really interesting phrase, lots of brilliant cognitive science on this, about people making decisions that are situational. In this place, at this time, with the information that I have, this is the best decision to make. Does that kind of make sense? I've got to be quick now, right? But don't go into that. You can have that on a sheet later. But that's where this came from. So now we're thinking, well, where does the complexity bit fit on this? And this is the bit. If you concentrate on the decision making and look at the typical evidence people are using in these 4 boxes, with a normal life, it's common knowledge. You don't look it up in a book, you kind of get on with it. You're talking about the problem, it's codified categories. We've learned it, measured it, we can teach it, we can delegate it, we can tell other people about it, and we can chop it up into university boxes. As we come out of that structure, foreseeable interpretation. That thing about we can't predict exactly where the crash is going to be, but we know it's going to be somewhere soon. So you prepare for it. And then when you're in the mess, it's a brilliant one called subjective evaluation, where you get somebody, you drop them in the middle of the mess, and they try and work out what the hell is going on. And if you drop a second person in the mess, they'll do it as well, and they'll work out something different. But those are equally valid ways of making decisions and gathering evidence. And complexity, interestingly, goes there. It kind of makes a mess of it. And the really important thing is, it makes a mess because of this. The patients and the punters are really difficult to define. They don't stay in these lovely corners. The nice, easily definable extreme corners of that model are easy. Most of our punters are actually moving between these types of things, between these activities, between these systems. And most of our clinical staff spend their time managing that transition from one state to another state. Because if you're going to stay the same, there's no work to do. Isn't it? But interestingly, it means that this model doesn't fit together quite as neatly as before. That these 4 types don't go together neatly. There's a bit of grey space. But you've got to remember that the complexity isn't just another box, a 5th box. It works more like that. Does that make sense? It breaks down the boundaries between those easily definable parts. And that's where the transitions exist. So, in that situation, the type of decision making is called a situational heuristic. That me and you will be in the same situation, we'll have a general rule of thumb that we'll use in that situation to work out what to do next. And when you take the next step, you have another heuristic to work out what to do next. So the question we've got for you in the breakouts is, oh, by the way, I like to call this no man's land. There's no Department of Middlebit or Royal College of Grade. It's type of people are left to it. You know, they qualify and then somebody drops them in it and says, carry on. So the question we've got for you is, to begin with, if we've got these kind of characteristics in this model go together, what type of mathematics works best where? Does that make sense? If you've got different tools and techniques in mathematics, where are those tools and techniques complementary to the characteristics of those types of systems? And there'll also be, for the operational people in the room and the clinicians and you two troublemakers, there'll also be issues and problems and operational delivery goals that also have those similar characteristics. So we're ready for breakouts. Does that make sense? Right.
Matt's given a great introduction to what we actually would like to be doing in the breakout sessions. On the badges, you'll notice you've got a wee sticker with colour on it. That indicates which person you're going to be working with in the breakout sessions. Just a small thing to mention at the start here, and that is that Lizzie Rouse, one of our PhD students, is going to be taking photos. If you don't want to be involved in those photos, please make yourself known to Lizzie as she comes across to the different rooms. So Lizzie is just here. Okay, so
You'll spot her, she'll have a big camera.
the aim of taking the photos is not to sort of catch you in action, it's to actually capture the picture that you'll be building during the breakout sessions and see how it's progressing over time. So those of you with a blue sticker, you'll be joining Julie in N1.02. So Julie, do you want to stand yourself up? And anyone with a blue sticker. Okay, so if you go out to the main area again, back up the stairs. Yellow sticker people are with Penny. Penny, do you want to make yourself known? Orange sticker people are with Isa in the collaboration room. Red stickered people are with Tracy in N027, so that's ground floor. Green stickered people are with Matt here in this room, so you don't need to go anywhere. So what we're going to do is have 20 minutes, and then we'll try and come back in here and try and do a bit of a sum up.
It's really important people move quite quickly because we don't have a huge amount of time to get the best out of it. Thank you very much. You can follow your leader and move out quickly. Thank you. Come on, finance. Come on, get moving.
Is that all right?
Yeah.
I'll catch up.